We're starting. Good afternoon. We are live. Are we live? Yes. Thank you so much. I want to thank staff again for getting us ready for all the material that they have been sending to us. I know that you will get the morning of the agenda. Thank you, Delegate Shalega, and the list of witnesses. There's a certain way it has to be done because we're virtual. It's not automatic, so staff has to actually do it manually, but they will get it together and make sure you get it every morning. What is really important, though, that will help them is that please be on time with your testimony. There's not going to be any exceptions made because it really adds to their workload. So if you do not get your testimony in on time, it will not be in the file. Plain and simple, and I apologize, but it really adds work to them when we do not adhere to the deadline. So good afternoon, and welcome to this briefing for the House and Health Government Operations Committee. It's a little hot in here today, and I apologize. We opened the windows in the hallway, so hopefully after we calm down, you can feel it. I'm starting to feel it. So bear with us. This room, it's the extreme. It's either very cold or very hot. No in between, so just be flexible. This is our first session back in person since 2020. So I ask for your patience. If we encounter any technical streaming issues, we will. We're trying to make sure things run smooth and staff is working really hard. This briefing is being streamed on the Maryland General Assembly YouTube channel. Panelists will control the transition of the slides. Before this briefing, all members were emailed a copy of each presentation. If you do not have these documents, please let committee staff know and we will send you a copy. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. Please keep your questions brief. Do not tell us a story, just ask the question so that we're not here all day. Please keep in mind this briefing is scheduled to conclude before 3 p.m., but immediately following this briefing, we have a bill hearing. And today we have quite a few bills and witnesses, so I need you to please make this a priority. And we do need 15 minutes between the time this ends and the bill hearing so the staff can log on to a new Zoom room. And they need time to be able to do that as well. Today, the Health and Government Operations Committee will hear briefings on osteoporosis from the Bone Health and Osteoporosis Foundation. We will then hear an introduction to Medicaid 101 from the Maryland Department of Health and the Maryland Managed Care Organization Association. We will begin with Ms. Vanessa Purnell from MedStar Health, who will introduce the first panel. And thank you. I see that you're there and ready. Ms. Purnell, good afternoon. How are you?
Good afternoon, Madam Chair and members of the Health and Government Operations Committee. As the Chair has said, my name is Vanessa Purnell, and I'm here on behalf of MedStar Health. With me today is Ms. Claire Gill and Mr. Peter Reinecke. However, before I formally introduce them to you, I just want to take a few moments to thank Jeremy Baker, Chief of Staff in the Speaker's Office, for his assistance. I want to thank Andrea Medeiros, who's the Senior Director of Public Health and Policy at the Bone Health and Osteoporosis Foundation. And I want to thank our doctor, Dr. Averam Galati, who is our research director for the Curtis Hand Center and our scientific director for orthopedics at MedStar Health Union Memorial Hospital. Please know that at Union Memorial Hospital in particular, we sort of specialize in knees, hips, and hand surgeries, so that when this issue was presented to us, we became very, very interested. He was very instrumental in our decision to enter into the pilot program with the Bone Health Organization the goal is to improve quality of post-fracture care in patients who have osteoporosis. Now, Ms. Claire Gill is the Chief Executive Officer of the Bone Health and Osteoporosis Foundation. She joined the foundation, which, mind you, was formerly known as the National Osteoporosis Foundation, in January 2013, after a 20-plus year career in public relations for national nonprofit organizations and public health relations firms serving Fortune 500 clients. She was named CEO in May of 2020 and then led the organization through an 18-month rebrand process. Established in 1984, the Bone Health and Osteoporosis Foundation is the nation's leading health organization dedicated to preventing osteoporosis and broken bones, promoting strong bones for life, and reducing human suffering through programs of public and clinical awareness, education, advocacy, and research. In September 2019, Claire founded and launched the National Menopause Foundation to be a trusted and relatable resource to raise awareness and understanding of menopause through education, activism, and community building. And to her immediate left is Mr. Peter Reinke, the Senior Advisor at Bone Health and Osteoporosis Foundation. And the Health Policy Institute, forgive me. He has worked on health and aging policy for the past 35 years. During an over 20-year career with the U.S. Congress, he's played a key role in the enhancement of numerous pieces of health and aging legislation, including Medicare payment reforms, Medicare fraud controls, long-term care reforms, and putting greater focus on wellness and prevention and health policy health programs. Peter has also worked for the Institute of Medicine, the National Academy of Sciences, and served as a visiting lecturer in health policy at Duke University. He is a resident in Montgomery County. So I would turn it over to Claire.
It's on.
Okay, thanks so much. It's a pleasure to be here. Thank you all for taking the time to allow us to speak to you today about something that greatly impacts not only our nation, but the great state of Maryland as well, and that's osteoporosis and bone health. Something that relates to all of us, and I'm going to say the word posture because scientists prove that when you say posture, we all sit up a little straighter, believe it or not, and it's absolutely true. You can't hear the word and not put your shoulders back, so thank you so much. Peter, if you could just click through for me. So we can skip that. As Vanessa had mentioned, we are the leading national organization for bone health and osteoporosis in the country. We serve a dual purpose. We do both patient education and clinical education. We provide continuing medical education. And the idea is to help prevent fractures in our population as we age. Many people think that osteoporosis is an old white person's disease, and that is not the case. One of our clinicians describes it as a pediatric disease that manifests as we age. You build all the bone density you're going to have by the time you're in your mid-20s. And the rest of your life, the body remodels the bone, it breaks down and builds up repeatedly throughout our lifespan, and that slows a little bit as we age. But for women, it drops dramatically at menopause. We lose up to 20% of our bone density in the first 5 to 7 years postmenopausal. So that's why people think it's a women's disease. And although fractures happen more in the white population, in the Black population, the instance of osteoporotic fracture, the results and the outcomes are far worse, even though the fractures are fewer. So we're going to address some of that today and appreciate, again, your time talking about it. I'm going to start by talking a little bit about why we got involved in advocacy at all. What we found was, as a national organization with a small staff in Northern Virginia, we have all the information anyone could possibly need about how to build and maintain bone and treat osteoporosis, but if we can't get it to the populations who need it, then what good is it? So we formed the Coalition to Strengthen Bone Health, where we reached out to all other organizations who treat the same audience. It tends to be, again, for those who fracture, the elder population. So you can see on the screen, this is our coalition members, where everyone from the National Council on Aging, to the Celiac Disease Foundation, to the Caregivers Action Network, are involved to help us spread the word about how important bone health really is to all of your constituents and to everybody in the United States. 54 million Americans are impacted by osteoporosis. 10 million have osteoporosis itself, and 44 million have low bone density, which means they're at a greater increase of getting osteoporosis. And what I want to cover on the national stats before we get into the impact on Maryland, you can go forward, thanks, is what we know is that fracture begets fracture. So if a person has a fracture, an osteoporotic fracture, the chance of them having another fracture increases 3 to 7-fold. So identifying people and stopping that subsequent fracture is essential. The data that we use with the actuarial firm Millman, it's 2016 data on Medicare beneficiaries, but as it shows here, 1.8 million Medicare beneficiaries suffered 2.1 million fractures. So just showing it's more than one that they're experiencing. 30% of hip fracture patients die within the first 12 months after a fracture. This is the stat I found when my mother broke her hip at the age of 81. Completely active woman, totally watched the news every day, was out and involved in our family, and the thought that my mom was going to die within a year just because she broke her hip was astounding to me. The 19% of patients with osteoporotic fractures will, again, have another fracture within a month. The idea here is, again, that if we can identify people with osteoporotic fractures, prevent the secondary fracture, we improve quality of life not only for the patient, but for their entire family and the caregivers involved, and we save money for the healthcare system. Next, please. Preventing secondary osteoporotic fractures by just 20% would save $1.2 billion in our Medicare system. And believe me, I spend so much time on Capitol Hill trying to convince your colleagues that this needs to be something that's addressed on the national level. But it is something that we can do something about on the state level as well, because when we do not address these fractures, what happens are those hip fracture patients end up in a nursing home and go off Medicare and onto Medicaid, and then it becomes a state problem. So really, working together to address this is essential. There are so many things that we worry about as we age, right? But we have things in place at the national level to address other chronic diseases. You would never go into a hospital with a heart attack and leave without being on an aspirin, at least, a beta blocker, a follow-up with your cardiologist, test to find out, what your blood pressure was, how to maintain it, advice on changing your diet and exercise. Yet, people enter a hospital with a fracture, they're patched up on the fracture, and they're sent home, and no one does any follow-up to find out if this person, we say anyone over the age of 50, it's not the older, anyone over the age of 50 who falls from a standing height and breaks a bone, osteoporosis is likely the underlying cause. And yet they leave, go back, have no knowledge of this underlying disease until they fracture a second time or a third time or have that hip fracture, and then mom or grandma dies, or dad and grandpa dies. So we at least need the minimum amount of care that we have for heart attacks, that we have for diabetes, that we have for other chronic diseases. And we're working at the national level to make the Centers for Medicare and Medicaid address this ongoing. If we don't address it, we will see a 68% increase in Medicare spending before 2040. That's to $95 billion. This is something we have the tools in place to address. We have great therapies to address. We know how to treat it, when to treat it, who's at risk, and yet we don't do anything to make this a priority within the medical system. These are more statistics for you about, again, the cost of a secondary fracture exceeds $30,000. and it cost $5.7 billion in 290,000 Medicare beneficiaries. So, but as we say, the statistics are much higher because we do not have the data on nursing home costs, on Medicaid costs, et cetera, on absenteeism from the person in the family who has to deal with a Medicare patient who has fractured. So now let's talk about a little bit more about what's happening in the state of Maryland. I'll turn it over to, inequities. Let me just address this again. So as I talked about, the fact that people think it's an old white woman's disease, but Black Medicare beneficiaries had higher hospitalization rates, higher death rates following fractures, and they never get screened for a bone density test. 22% died within the first 12 months after their initial osteoporotic fracture, again, compared to that 19% average. 35% died within the first 2 to 3 years, which is greater than 10% the national average. They're 30% less likely to get any post-fracture physical therapy and 2.3 times higher risk of destitution in the year following a bone or vertebral fracture. This is uncalled for. It's unnecessary. We know how to address this, and we must.
I'm going to talk just a little bit about just say it's a privilege to speak to you all as a Maryland resident, and particularly your first in-person meeting. So the same study that Claire referred to nationally looked specifically also at Maryland, the impact on Maryland. We have a written report we can provide you with a full copy of the details, but a few of the highlights, about over 28,000 Medicare beneficiaries in the state of Maryland suffered 33,600 osteoporotic fractures in 2016. And the cost of the care for those individuals, and again, this is just the Medicare costs, was over $24,000 over the next year following the fracture. That was more than 2 times the national average for a person on Medicare in Maryland. And if you look at the 5,000 Marylanders who suffered more than one fracture, a second fracture, the cost for just those 5,000 was an estimated $130 million in 2016. And we know, as Claire mentioned, that there are steps that can be taken to substantially reduce the percentage of people who have a first fracture who then go on to suffer a second fracture. And we also know, just for the Maryland numbers, that for every time we stop a second fracture, the savings are almost $24,000 in the next 6 months. And also we know that about 4,900 Medicare beneficiaries in Maryland died following their fracture. Just also to follow up on the number of people screened in Maryland, 8%, only 8% of Medicare beneficiaries who had a fracture were actually even screened for osteoporosis within 6 months of suffering a fracture. And for Black Marylanders, that number is lower, just 6%. Maryland's costs are in the average range. That Arkansas was highest with 26,000. Maryland's at 24,000. Wyoming was lowest at 17,000. And over Maryland here, we're higher on the higher end of things in terms of mortality rates. We're at the highest was 21%. Maryland is at 20%, and Hawaii and Alaska are lower at 14%. So what can be done? One step is just raising awareness amongst the population about the importance of bone health and the steps they can take in terms of building bone mass and knowing when they need to do that and how they can do that. I know, just for my own personal sake, we have kids who are in elementary school, and they are not drinking as much milk as kids did earlier when I was a kid. And so, what are the kids these days in the state doing to to get their calcium to build that bone mass that they need to avoid problems with their bone health into the future. We also are urging you to consider calling on your federal congressional delegation to take steps to get Medicare to improve its care coverage for osteoporosis, and also to encourage state residents to get screened for osteoporosis if they're at risk or have a bone fracture over the age of 50. And those, I can say that the U.S. Preventive Services Task Force does call for regular bone density screening in certain age groups. Claire, do you want to wrap up?
Yeah, I would just like to remind everybody again that this is something that impacts all of us. The statistics are that half of all women over the age of 50, so Madam Chairwoman and Aaron, that means one of you two sitting up in front of us will break a bone due to osteoporosis in our lifetime. And the same for the rest of us around here. And for men, it's 1 in 4. So there's more than 4 of you in this room. That means one of you will break a bone due to osteoporosis in your lifetime. This is something we have to address. It is an awful, painful way to end your life. And again, there's a lot that can be done on the state level to raise awareness and make this something that the great state of Maryland can have the best and healthiest population in bone density instead of the average or the worst. And thank you so much for your time.
I was going to say, some of us have already broken some bones. But anyway, I'm going to open it up for questions. I have delegates, and thank you so much for coming. We really appreciate the information you have provided, right? Prevention is so important. And there's, with a lot of these public health issues, it's spending a little bit in the front, right? To save later. So thank you. We really appreciate you. So we have Delegate Shalega.
Thank you, Madam Chair. Thank you for being here. In the beginning of the presentation, Claire, I think you said at what age you build bone density. Can you rewind it and tell me that again?
Yeah, we build all the densest, richest bone we're going to have, the strongest bone, by the time we're 25, mid-20s. So you really do need to get children consuming calcium, vitamin D, weight-bearing exercise, and muscle strengthening exercise, so anything on our feet. That carries through the rest of our lives. When we talk about what do we need to do at this age, weight-bearing exercise, muscle strengthening exercise, calcium, and vitamin D. But for children these days, as we know, with the obesity crisis, they're not getting a healthy diet. They're not drinking milk with the milk mustache like we had growing up. And so we're gonna have a crisis, continuing crisis of generations who don't even reach peak bone mass. At least we reached peak bone mass, right? We were getting that calcium and vitamin D. We were outdoors playing, we were jumping. So, and then we have the loss that gradually happens. The rest of these generations aren't even reaching peak bone mass.
Thank you.
Thank you for the question. We have next Delegate Johnson, followed by Delegate Taveras.
Thank you, Madam Chair.
My pleasure.
Whoever's best to answer the question. I know you gave us some national numbers. If we could reduce the secondary fractures by 20%, we would save $1.2 billion. Do you have any number for us if we could reduce 20% of secondary fractures in Maryland? What the savings would be?
Our estimate from the Milliman firm was that the secondary fracture cost for Marylanders on Medicare was $130 million. So 20% would be $26 million.
All right, thank you. Thank you, Madam Chair.
My pleasure. We have Delegate Taveras, followed by Delegate Collison.
Thank you. I just have a quick question. I mean, you said that, I was like, did I see it correctly? That was 70.5% of the victims were women. And so maybe this sounds like a particular question, why men also experience some type of menopause and why don't they see the same level of exposure?
For men, it just happens later. The dramatic loss of estrogen, the stop at menopause is why it happens to women faster. But right now, the guidelines say that a bone density test, it's part of the Welcome to Medicare package. You should be able to get a bone density at 65. But I can't tell you how many women are asking me at 50 why they can't get a bone density test when their mother has had osteoporosis, their grandmother has osteoporosis, et cetera. We really do need to address the fact that earlier, preventative, and not just post, is when people should be screened for bone density. I also say the same thing. There's so many tests that we have that are painful and intrusive. I'm thinking mammograms, I'm thinking colonoscopies if you've had them. Awful. Bone density test, it's non-invasive. You don't have to take your clothes off. It's incredibly accurate. But I keep telling people, we need to tell men and women that you're beat over the head and it is the most painful thing in the world. And then maybe we'll line up to get them the way we do mammograms and colonoscopies.
Thank you.
Delegate Collison.
Thank you, Madam Chair. So I'm not sure if this is a chicken or egg question, but we've heard in this committee a number of times that falls are one of the greatest risks for folks my age and above. So is it the osteoporosis that contributes to more falls, or is it that because of osteoporosis we're more likely to get a fracture if we do fall? So that fits into the public awareness campaign. So if you just speak to that for a minute.
That's a great question. The reason, and I think fall prevention is the easy one, right? Everyone can relate to fall prevention, and there's billions spent on fall prevention programs. The only reason it matters that you fall is because if you have osteoporosis, you're going to break a bone. You should be able to fall from a standing height and not break a bone at any age. So if you fall and break a bone, the chances are that you have a weakening of the bones, the osteoporosis break. And there's some people who have osteoporosis and fall and don't break. So that's lucky too. It really depends. But the bone weakening can make it something where, again, you might be more likely to fall, but you should be able to trip, fall. And we all say that, oh, I slipped on the black ice. I broke something. No, you should slip on the black ice and just slide. You shouldn't break. And so breaking of a bone after a fall is essential. But fall prevention is what we try to encourage all people to do, particularly as we age, so that you avoid the fracture.
Thank you.
Delegate Gazzoni.
Thank you. Wanted to get a little bit more insight into post-fracture care and what should be getting recommended to folks. I've had my mother-in-law passed away within that year after having a hip break. So I've also had 2 bone density scans. So if anybody hasn't had one, easy peasy lemon squeezy and very quick. So
Typically after a fracture, what should be done is, besides immediately treating the fracture, you should have a blood test done to check your vitamin D levels. And to also find out if there's an underlying cause that led to the osteoporosis. Things like parathyroidism, et cetera, stuff can be an underlying cause. You might have other conditions that have led to bone loss. So a workup afterwards, the bone density test afterwards, and then depending on the level and severity of the bone loss, you might need a medical treatment. They will give you advice about changing your diet, doing exercise, et cetera, but unfortunately diet and exercise alone cannot reverse or prevent bone loss further. So you really do need to think about whether or not a treatment is required. The good news on treatments is the effectiveness of our treatments are better than cholesterol drugs, better than the beta blockers, all of it. So the treatments are quite well and quite sufficient, but nobody's on them. There's an 80% care gap in the people who fracture due to osteoporosis and get any post-fracture care. That's crazy. So what we're trying to do with Medicare right now is to have a reimbursement model for what we call the fracture liaison service. A little bit like diabetes educators or the cardiac care that would happen afterwards. We call it, and it's proven internationally and domestically, that the fracture liaison service works and helps prevent secondary fractures and can reduce costs, but it's not common and clinicians can't get reimbursed for it at the moment. So we're trying to work at least within CMS that be the standard. Anything else? Did I miss?
Because typically
So
what
we
happens-
only allow one person to answer. Sorry about that. and you can actually speak to the delegate offline. Okay, thank you. We have no other questions. I just want to give you some friendly advice. If you should work with the Department of Aging regarding doing some messaging and campaign in the community. Regarding the minority community, the Office of Minority Health and Health Disparities, they're actually tasked with taking on these issues and developing campaigns for the community. And also, I think that MedCai has a role here, right, for providers. As we speak at home, I have an order for my bone density that I haven't scheduled yet. And it's been many months. But I think that there is actually an opportunity to work with the providers to make sure that they're aware of it as well. So I think that you should definitely link with those offices. And it will be a good partnership. And if you need us to help you with that, contact my office and we'll make the introduction, okay? Thank you so much. Have a wonderful afternoon. Thank you for being with us today and for providing such valuable information. And to our committee, we have Medicaid 101, and we do have a lot of presenters. First, we have the Maryland Department of Health. We have the acting Medicaid director, Tricia Rowdy, followed by the Executive Director of the Office of Eligibility Services, Ms. Debbie Rupert. Good afternoon. And as they sit down on Sunday, there was actually an article in the AP, the Associated Press, about Maryland and how we, according, I believe, to the Maryland Health Benefit Exchange, Maryland can lose up to 80,000 people that can come off Medicaid. So with that in mind, I just came out 2 days ago. So I know you're going to address all of that. So we're all yours. Good afternoon. How are you both?
We're great. Thanks, Chair Pena-Melnick and other members of the Health, Government, and Operations Committee. Thank you for having me back from last week. And with me, I have Debbie Rupert, our Executive Director for Eligibility Services. She's been with the department for 15 years. I've been with the department for 22 years. So we know a lot about Medicaid, and we're here to talk about Medicaid in general. I know I zeroed in last week on long-term care. So I'm going to only touch upon long-term care a little bit today and focus on the other parts of Medicaid. So generally, if you think back, there's probably been 3 big expansions from the federal government around Medicaid. So initially, it was established in 1965. At that point, it was really for children and sort of low-income parents and, of course, individuals in nursing homes. And then, of course, there was the Children's Health Insurance Program expansion in 1997. And, of course, Maryland took up that expansion. And then, of course, you can all remember the Affordable Care Act that went into effect in 2014, where we, again, expanded now to sort of the childless adult population. Medicaid is funded jointly, so it's funded with state dollars as well as federal dollars. The matching rate follows the individual, so generally for parents and lower income children and long-term care individuals, we're getting about a 50% match. The higher income children that are covered under the Children's Health Insurance Program gets around a 65% match. And then, of course, the populations that were expanded under the Affordable Care Act get 90% match. So there is a saying that no one Medicaid program looks alike because we have the ability to design our programs within federal parameters. The federal government that approves our program is called the Centers for Medicare and Medicaid Services. We are the payer of last resort, so if there is another payer that's available to pay for the services, we are supposed to do our best to make sure that they pay those bills. And with that, that means that individuals under Medicaid can also have other insurance. I think sometimes that is forgotten, that individuals in Medicaid will also have Care First as a third-party coverage, as well as other commercial plans. And of course, you can also qualify for Medicare. So there are individuals who meet our income standards who also qualify for Medicare. And those individuals are called dual eligibles. Again, no one state Medicaid program looks alike. There's certain mandatory programs that eligibility populations that we have to cover. There's mandatory benefits, certain provider requirements, but we do have the ability to make changes within those and expand to different populations, offer additional benefits, pay different rates, et cetera. You'll hear us talk about what's called a state plan amendment. That's essentially the documentation that we have to submit to the federal government to get approval. It outlines what we're covering, what our payment rates look like. So they develop and approve the guidelines. And then, of course, after we develop and get CMS approval, we submit regulations in which we follow. Again, just to let you all know, generally when we cover a service, it has to be adequate in the amount, duration, and scope. We have to cover things statewide. We can't vary services based on diagnosis or condition. We have rules, federal rules, on how we can implement cost-sharing requirements. In Maryland, we only have a nominal pharmacy copay, which is $3 for preferred drugs, brand name drugs, and $1 for generic, and $1 for preferred drugs and generic, and $3 for non-preferred and brand. The federal government does allow you to do a bit more for the higher income populations, but we have not implemented any of those rules. Again, we have federally mandated benefits that we have to cover. Inpatient services, physician services, nursing facility services. One that you'll hear us talk a lot about is early periodic screening, diagnosis, and treatment services. It essentially, if it's medically necessary for children, state Medicaid programs must cover it, is what that federal rule basically tells states. What you'll be surprised about is some of the optional benefits. For example, we don't have to cover pharmacy, which, I can't imagine offering healthcare services without a pharmacy benefit program attached to it, but that is an optional benefit. Mental health services is optional. A lot of the long-term care services that keep individuals into the community is also an optional benefit. This is a nice chart that shows you our income levels. So when the Affordable Care Act passed, for many of our populations, they no longer have an asset test. And so a lot of you might think that we always say we cover children up to 300% of the federal poverty level. When we had to map it, it gets a little complicated to the modified adjusted gross income standards. So you had to take into consideration all the disregards you had and translate it into what it would be in an FPL level. So our highest income level for children is 322% of the federal poverty level, and then the childless adults are at 138%. I touched upon
this.
this.
May I stop you for 1 second, if
Sure.
I may, respectfully? Can you just tell the committee what is that income bracket?
So generally, 300% is around, for a person of one, it's 43,740. For a family of three, it's 74,580, to give you a sense.
Thank you.
There are, as I talked about last week, there's 6 ways essentially for individuals to get eligibility through that attaches long-term care benefits. If you're age, blind, or disabled, and you're receiving supplemental security income, you're automatically enrolled in our programs. If you're in nursing homes and you spend down and you have income at the level that qualifies under Maryland, you'll become eligible. And then, of course, as I talked about last week, we have a number of different optional home and community-based waivers programs. We operate the program of all-inclusive care for the elderly. That's a capitated program that where Medicare pays a capitated amount as well as Medicaid. So it's an integrated program with both Medicare and Medicaid benefits. And then, of course, if you're low income, for Medicare, we do pay your premium and cost sharing amounts. As I mentioned last week, unlike the Affordable Care Act populations, there still is an asset test for these long-term care eligibility groups. And outlined in this table are both the income as well as the financial asset tests. For qualified aliens, so they're legal permanent residents, you have to meet what's called the 5-year bar in order to apply and qualify for Medicaid. There are certain populations that are exempt from that, children and pregnant women, so you don't have to meet the 5-year bar for you to qualify for Medicaid. If you're a qualified or recent lawfully present immigrant and you haven't met the 5-year bar, you can still qualify for health care insurance in the exchange. And then, of course, I know a topic and population that you all are interested in is the undocumented and non-qualified aliens. So those are the individuals that aren't able to receive Medicaid coverage. As you know, there was the Healthy Baby Equity Act last year that passed, and that allows us to cover non-citizen pregnant women through the baby. And so we are implementing that program. It's due to go live next July 1st. And we will cover postpartum care for those women as well. It gets a little bit tricky, but we are allowed to spend a certain portion of our CHIP allotment on non-eligible or non-covered benefits. And so you can get special permission. So that'll allow us to cover these non-citizen pregnant women after they have the baby in their postpartum period. Give you a sense of where we are right now with enrollment. We're about 1.7 million people. 700,000 of those are younger than 21. And just to give you a sense of how large we are in Maryland, we cover about 80% of the births in Maryland. 86% of our population receives their services through managed care organizations. And managed care organizations get a monthly capitated rate for their population. It's risk adjusted in order to provide those services. We have 9 MCOs, and we've listed them here, and you will hear from a few of them in a few minutes. And they're ranked in order in terms of how big their Medicaid population is. Priority Partners, WellPoint, Maryland, which was formerly AmeriGroup, Maryland Physicians Care, United Healthcare, MedStar, Kaiser Permanente, Care First, Aetna, and JAI. There are people that are not eligible for managed care in Maryland. Those are generally your dual eligibles, those individuals who are eligible for both Medicare and Medicaid. Individuals that are in a nursing home are not eligible. People who spend down, so those are people who aren't eligible but have significant medical expenses. They can spend down their income and then qualify. There is one waiver program that we do not allow individuals to enroll in a managed care program for, and that's the model waiver for medically fragile children. Those children must be enrolled before their age of 21, but that's the one waiver program that you cannot be in Health Choice as well. We do not put individuals who have family planning only benefits into the MCOs. And then, of course, they are not enrolled prior to selecting an MCO. And then you'll also hear that we offer a rare and expensive case management program. This is a program, it's by diagnosis, and if the individual is eligible to be in an MCO and they meet one of these diagnoses, they can opt out of the MCO and receive enhanced case management through the fee-for-service program. There are some services that our MCOs do not administer themselves, and I know that you've heard a lot about some of these services. So the main services are behavioral health services that are carved out, as well as dental is carved out of our MCO model. And then, of course, just to reiterate, individuals over 65, individuals who can be in the managed care program, but their home and community-based services are provided on a fee-for-service basis. And then, of course, if you're eligible for both Medicare and Medicaid, you are not eligible for Health Choice. You will hear us talk a lot about the 1115 waiver, demonstration waiver. So this is the 1115 demonstration waiver allows states to pilot different programs, innovative programs, and it also allows us to restrict things that we normally would not be able to restrict. So we can restrict based on geographic region. We can start capping programs. We can, limit it to like a certain, like I said, geographic, you can cap programs, you can limit to the diagnoses, you can do things that generally you're not allowed to do in the straight state plan amendment programs. And we've been operating this program since this waiver, demonstration waiver, since 1997. Believe it or not, in 1997, managed care was a demonstration program. CMS has since changed that, but there are certain populations that still need to be covered under an 1115 waiver in order to enroll them in managed care. So essentially, we have a very mature demonstration managed care program. Talking about some of the pilot programs that we have under our 1115 waiver, you've heard us talk about the maternal opioid misuse program. This is the demonstration program that provides case management services to mothers, pregnant mothers who have opioid disorders. We also, two of the big demonstrations that we have under the 1115 waiver right now is we cover substance use residential services for individuals between 21 and 64. That, again, that normally, in terms of CMS's policy in the past, that's been the responsibility of the states. Just several years ago, they allowed us to put this under an 1115 waiver and receive federal matching dollars. Additionally, they are now allowing us to cover individuals between the ages of 21 and 64 in a psychiatric facility. We can cover them up to a 60-day stay, and in total, all the population served under that program, we have to meet a standard of an average length of stay of 30 days. Additionally, one other one that I would like to highlight is the Assistance and Community Integration Services. It's a very small demonstration, but we are really testing housing in this program. We give targeted case management to and housing support services to individuals who are at risk of institutionalization, at risk for losing their housing opportunities, and they do have a frequent inpatient admission rate. And so what we are almost done with our evaluation for that program, and we would love to share the results with you when it comes out, but we're seeing some, from the preliminary data, some really promising results with that. Also, to name a couple of the other ones, we do have the diabetes prevention program that we're covering under the 1115 waiver. And another one, we are piloting a collaborative care model where you're providing psychiatric services in the primary care office setting. And again, we'll have some results from that study within probably springtime. We'll have those available. And with that, we wanted to turn it over and talk about, I think everything that everyone is hearing about and talking about today is the public health emergency and what that means for Medicaid and redeterminations. And I'm going to work the slides and let Debbie kind of take it.
Well, this is a subject near and dear to my heart, Chairman and committee members, as you've heard us talk over the many years about the renewal process. And as you know, the Family First Coronavirus Act allowed us to continue to receive additional FMAP of 6.2 as long as we maintained our continuous coverage. At that time, Maryland made a very good decision compared to some of the issues that we're hearing faced in other states. We chose to keep our course. At the time of this decision, we were processing 98% of our applications through the Maryland Health Connection in 24 hours. We're still processing that. By us continuing our operations, it didn't come easy. There were, operational impacts, staffing impacts, all the things everybody else experienced. But we kept our course, and this allowed us to stay in contact with our members. So we've been doing renewals over the entire time, which allowed us, and we've had a very high percentage of individuals do the renewals. Currently, we're averaging 55% of every monthly renewal is auto-renewed, and that's because we have systems in place that we use, unemployment data, federal hubs, information that allows us to check someone's eligibility without even going to the individual. So we are really ahead of a lot of states. In fact, Washington and some others are reaching out to us wanting to know what our percentage is and how we're doing it. We're continuously looking and analyzing the data to see what else we can help to improve our percentages. Last year, we added the unemployment data because we recognized that a lot of our recipients were receiving unemployment, and so if we could tap into that without relying on them, we wanted to do so. So we're very aggressive in analyzing those opportunities. So there have been changes, as you probably heard. The PHE and the CE requirements that were part of the maintenance of effort are no longer linked. With the Consolidated Act, which became law in December 29th, we are now moving forward with renewals. Our first renewal, and when I say first, I don't mean that because we've been doing it the entire time. Our first renewal as the unwinding process, our redebts will go out in April. We have two systems to process our eligibility. One is the Maryland Health Connection that takes 45 days to get those applications out. And MD Think, the DHS system, which we allow 60 days for our age, blind, and disabled population to get those renewals out. So our outreach renewals will begin in April. They'll have advance notice to complete their renewals, and we'll have resources on staff to assist. We've increased our local health department grants to ensure overtime, extended hours, community events. So we're really prepared in being able to assist those individuals that aren't able to do the renewals on their own. So the first set of renewals are scheduled to terminate on May 31st. We're very fortunate in Maryland, we have a 3-month retro. So if someone, and we've noticed this in the past prior to the pandemic, that individuals usually come back after they go to the doctor, the pharmacy, find out that they've lost their coverage, they come back. And in Maryland, we have the 3-month retro. So if they come back within the last 3 months, they can apply for coverage to cover that period in which they were exposed and didn't have the service. So there's a bridge to eliminate financial exposure for those individuals. And as you probably heard, President Biden announced that the PHE will be ending on May the 11th. And Maryland's disaster spas, 1135 waivers, Appendix Ks, and authorities remain tied to the PHE. We're currently looking at some of our waivers associated with eligibility to see which ones we will be able to continue after the PHE. The next slide shows you the timeline that I just showed, reaching out and mailing our mailings in April with the first renewal in May of 31st of 2023. This is just our timeline and another one. So one of the things we hear all the time is everybody going to lose coverage on May 31st. They're not. CMS has allowed us 12 to 14 months in order to continue to do outreach, and we've elected to stay the course, to do our small renewals on a monthly basis. And so this timeline shows that we'll continue this, meeting the CMS of requirements of extending renewals over the next 14 months and through May of 2024. The Congressional Ombudsman Spending Bill will allow us to continue to receive FMAP with certain requirements, as long as we meet certain requirements that CMS is mandating. And this just shows the wind down of the FMAP starting in March of 2020 to March 31st. We were at 6.2, and you'll see that we decreased from 5 to 2.5 to 1.5. And the next slide shows this in a different format, just in a different way. So you'll see the decreasing in the FMAP. Communications, Trish and I talk a lot of time about communications. We don't get to have a lot of marketing and buses and campaigns, and so we're very lucky with our MCO partners and some of the resources that we're actually going to be able to do some marketing campaigns. We're partnering with all of our stakeholders, such as our MCOs, the Maryland Benefit Exchange, DHS, who is our contracted Medicaid partner, Chris. And the communication campaign will include paid media, social media, messaging, advertising, digital campaigns, and in addition to targeted outreach efforts by our MCO. We have been sharing our files, which was a recommendation to CMS. We've been sharing with our files with the MCOs for many years. And so we not only send the renewals out, but through our outreach efforts with the MCOs and the local health department, we do outbound calls to ensure and to help them if they're having difficulties not getting the renewals done. And so we're really excited about some of the campaigns that are coming. As I mentioned earlier, we coordinate with DHS, who is our contracted Medicaid provider, and DHS offices has resumed their redesk just as we did with the Maryland Health Connection. DHS is hiring additional staff. Those staff won't be dedicated to Medicaid because, as you know, on the DHS level, they handle all the associated benefits, SNAP and others. But it doesn't mean that, you know, when a Medicaid comes in that they wouldn't. And because, you know, we're working with them to align the renewals with their other associated benefits, which allows us to serve that individual for all programs at one time. So that's really exciting. Protocols are in place to ensure warm hands-offs between our call centers, DHS, MDH, and the Maryland Health Connection. And information will also be available to all consumers on the website. That's one method where we've continued to notify all of our physician partners, all of our recipients, that they didn't have to do renewals. So we'll continue to update that and keep that available for them.
Yeah, a couple other things to highlight. Our providers are very interested in helping us with making sure that we keep everyone enrolled in Medicaid who is eligible. So we're putting together a provider toolkit. We're also working with CRISP, the Health Information Exchange, so that we can put within their system the redetermination date so that when they can outreach themselves to their patients, if they're in the office and they're being treated, they can mention it at that time as well. So we're working on building that functionality so that providers can be a critical piece in this outreach effort.
And one of the critical items for us to be successful in renewals is them getting the notice. And so some of our communications are at a provider's office. If someone comes in and reports that they changed an address, being able to give them a flyer or information to say, don't forget to go on the exchange to update your information, you know. So we've been practicing that campaign for many, many years, using them to, advising them to come in and make those changes, and that's another way that our physicians' offices can help us.
Now, I know we're leaving a little bit hanging because I know the panel up next is going to give you our, our marketing campaign, but we have been working very closely with our managed care organizations. And as Debbie mentioned before, we're doing this right. I mean, we actually hired a company, GKV. They did focus groups. They went out and, you know, are tailoring the message based on what they heard. And we are really spending money on this effort. And I have to say I'm on a lot of calls, national calls, and I don't hear any other state doing what we're doing. So again, I think I don't want to leave you hanging here, but they're coming up behind us with a good splash for you all to see in terms of some mock-ups. But with that, Debbie and I are both happy to answer any questions.
So for the MCOs, the pressure is on, okay? So I thank you for the information you provided. I'm going to open it up now for questions from the committee. Are there any questions? I have first Delegate Robin Lewis.
Thank you, Madam Chair, and thank you so much, Ms. Roddy and Ms. Rubert. Thanks for all you do year-round, not just in our emergency situation. I spent a couple of years working at the Maryland Health Benefit Exchange, 2014, when our amazing IT team was rescuing the broken, website and fixing it. And I just remember all the constituent services we had to navigate during that time. I'd like to know from you what you anticipate, having lived through that, I know you both lived through that, what we might anticipate in terms of potential falling through the cracks, Marylanders who might get lost in the shuffle, and of the 80,000 or so who are at risk of losing Medicaid when the emergency is null, what you think we might see and how we can work with you to take care of those folks.
Who will you direct that question to?
And I think, if Madam Chair, if I may, whoever's best positioned to answer, because we can only have one answer.
Sure, I'll take it. That's fine. I'm happy to. So I think some of the areas that we'll want to pay attention to is our call centers. We want to make sure that they're staffed up and that they're able to handle the volume. What I will say, with the additional FMAP that goes out to December, there are federal requirements that come along with that. So we need to do our best to make sure that we outreach to people as best we can. So we need to make sure that we don't close any case without doing a full redetermination. And generally, if folks do fall off, there's a couple of items that we are working on with the exchange. How do we get them into a QHP? The legislation passed, I believe it was last year, that provides a special enrollment period for individuals who are eligible for Medicare.
We did.
So we need to make sure those warm handoffs occur and that connection is being made. But we also need to make sure if they truly are eligible and they are receiving services that, and we, in Medicaid, we have retro coverage. So we go back 90 days and we can get them back enrolled and we can pay those claims. So I think, that's a kind of highlight of sort of where we're thinking about the touch points. We are going to do our best to make sure that we keep everyone who is eligible. And I know there's numbers out there, but I will say personally that you never know what's going to happen until you start the redeterminations. People's circumstances definitely changed over the pandemic. People switched jobs, their income really dramatically changed. So we don't really know how it's gonna fall out. We have some predictors, you know, in terms of some of those numbers that were used, but really we don't have we will not know until we really get into this and start doing the redeterminations.
Thank you. We have next Delegate Collison, followed by Delegate Taveras, followed by Delegate Bagno.
The optional benefits that
Yes.
Medicaid can provide, are those all determined statutorily? Do they have to come through the General Assembly, or can the Health Department make decisions around that?
We can make decisions. So, you know, I think generally we follow, of course, if there's a statute requirement, but generally the Medicaid program with the governor and DBM can find the funding, and we can implement certain expansions. We can do that through the state plan amendments, and then, of course, through regulation.
My pleasure. Next, we have Delegate Taveras.
Thank you. On page 11, at Maryland Medicaid at a glance, I just want to make sure that I understand correctly that of all the births in the state of Maryland, 80% receive some type of medical assistance, or is it Medicaid?
Sorry, so Medicaid and medical assistance is interchangeable in our world. So yes, they're covered under Medicaid. We pay for those births.
Of all births?
All births in the state of Maryland, yes.
So that's the only people populating at the bottom? Okay. And risk adjustment, what do you mean by that?
Risk adjusted, it means, so, you know, we need to make sure that we're compensating our managed care organizations fairly. So we need to pay them, if individuals have higher needs, higher diagnoses, we need to pay them more. So we risk adjust based on diagnoses, geographic region, gender, et cetera, to make sure, again, that we're fairly paying them to care for our populations.
Thank you. We have Delegate Bagno.
I think my question might be answered by the next panel, so I'm going to refrain. Thank you.
Thank you. Delegate Collison, you have a question? Okay. Okay. It's all right. I want to make sure I don't miss anyone. Anyone else? Okay. So can you tell the committee, out of the 1.7 million people on Medicaid, how many are children? And out of the 1.7 million people on Medicaid, is the coverage, can you fairly say that they come from all 24 jurisdictions in the state of Maryland?
Yes, I can say we cover all jurisdictions. I'm sure the percent of that county varies, but we cover, we enroll people across all counties.
And I want to thank you personally for continuing the re-enrollment, which I know some states chose not to do that. I know. Yeah. And that's a pretty dark picture to get caught up. So thank you for the work you do. I know you're very committed, both of you, and we thank you for that. And if you can keep us posted, this is a very important issue, as you know, for, you know, the administration, but, you know, for us, the committees in the House and in the Senate, because we have worked so hard to cover people. And we know that there's still people out there that qualify, that have not actually applied for Medicaid as well. So thank you very much for your work. And let's see if they're going to splash. How high is their splash? So next we have the Maryland Managed Care Organizations Association. And we have the Executive Director We also have the CEO of United Healthcare and the Vice President of Government Relations for WellPoint. Welcome. And who would like to get started? 1 second, please. 1 minute. Will you be so kind and make sure the microphone is on? Thank you. All right. Thank you for your patience. Go ahead.
Good afternoon, and Chair Peña-Melnick and members of the committee, thank you so much for having us. My name is Kathleen Wee. I'm the CEO of United Healthcare's Medicaid Health Choice Plan, but today I'm here representing the Maryland Medicaid MCO Association. I'm the chair of the board representing the 9 MCOs that participate in the program, as Tricia covered. Before we kind of get into the slides, I just wanted to reflect on some of the comments that both Tricia and Debbie made, that absolutely, Chair Peña-Melnick, you pointed this out, half of the plans that are in the Health Choice program, half of us are national organizations that participate in Medicaid managed care programs in many other states. And when I talk to my counterparts in other markets, the level of collaboration and preparation that the state has facilitated for us, I am just simply not hearing, right, from my peers. I just wanted to thank the Maryland Department of Health and you all as a committee for your long-term commitment to the Medicaid program. As Tricia covered, this state has a very broad and deep Medicaid program in terms of what it covers, how many people it covers, and it's a statement that there's 1.7 million Marylanders on this program today, and we are all just very privileged to have the opportunity to serve them. The piece around there's many states that are not doing redetermination, or they haven't been doing renewals for the past 3 years since the COVID pandemic began. The fact that Maryland has been doing that throughout really, and then also sharing the data with all 9 of us. Each one of us has a very good sense of, which of our members need to go through the process. The auto-renew component gives each of us a certain percentage of our membership that really doesn't need to do much, right, to stay on the Medicaid program. And then also, we know which members are most likely to be ineligible and when those members' dates come up so that we can outreach and invest, right, in helping the members, the providers, and our community partners focus on those members at the time that they really need to act, so that we're not alarming members, right, who actually don't need to do something at that point in time in order to maintain their coverage. So just wanted to kind of note all of those just incredible advantages that we have just in being health plans here in the state of Maryland. And I'm going to kind of advance a couple slides because some of this overlaps with some of the comments that Tricia made. But again, of the 1.7 million people who are in the Medicaid program today, 1.5 million of them are enrolled with one of the 9 of us. That's 24% of all the people in the state, right, that are receiving services from one of the 9 plans. And again, 47% of our membership are children under the age of 18. Kind of a last point, I think that all 9 of us are very committed and engaged in assuring access to prevention and to primary care to make sure that we're caring for our members in the best and most cost-effective way. All 9 of us are accredited with NCQA, which is a national organization that monitors, kind of quality and performance of Medicaid health plans. And all 9 of us also are above the national average in terms of quality measures and member experience measures for calendar year 2022. So this state has, as Tricia mentioned, a very mature Medicaid managed care program and a high-performing program relative to other states. These are the 9 brands, right, for the 9 of us. So hopefully these are all, familiar names, and you've heard about all of us and serving the members in your jurisdictions. We together, as the 9 of us, the association is not as old as the program, right? The program has been here since 1997, but the association formed more recently than that. But through a recognition, and actually, I think the COVID pandemic, and then now followed by the end of the public health emergency and the unwinding of Medicaid continuous eligibility, that's really actually highlighted the need for the association. It's given us a forum to work together and to work with the Maryland Department of Health and with the MHBE and other, and with you all, to really make sure that we are kind of tackling at a program level, those crises for the state and for our members, so that, to make sure that we have coordinated execution and a program-wide approach when that's necessary. The next slide shows the other thing unique about this association is that all 9 CEOs of all 9 plans are members of the board. So this is a very leader-driven association, which is terrific. I just wanted to acknowledge Jason Rotman, who's sitting behind me, who is the CEO of Maryland Physicians Care. So all 9 of us have been very active, working with each other and working with the department throughout the pandemic. I mean, obviously there's a history of that pre-pandemic, but I think it took it to a whole nother level, right? When we were faced with all the challenges that all of us had to deal with throughout the past 3 years, and then now heading into redeterminations for Medicaid. As Tricia noted, as a board, I think maybe even as long as a year ago, we all came together and agreed that we needed to make, I think each of us has our own individual approaches and plans, right, around outreaching to our individual members. We have the data to do that, to help. We obviously have tremendous interest in maintaining the members that we serve. So each of us is investing significantly in that ongoing effort to help our members renew. And we're going to take that probably to the next level, right, as we head into April, when we really have the potential, right, for members to actually disenroll, right? That hasn't happened for the past 3 years. But in addition to those individual efforts driven by each of the 9 of us, we decided to make a shared financial investment in a campaign with GKV that Tricia referenced. We selected GKV, and Jennifer Bremen, our executive director of our association, she's going to review for you, what the work that GKV has already done. We were thrilled when the department decided that they also wanted to contribute funding to this campaign to stretch out the impact that we can have. But this campaign is going to give us a single brand, right, for this activity that each of the 9 of us can use, so that our members see and hear a consistent, message from all of us, but then also is a set of tools that we can then provide, right, to, anybody in the state, right, that is, in the state government, right, that's working with our members, but then with our provider partners, with community-based partners who we know are trusted advisors to our members. This is an investment that we're very excited about, and I'm going to turn it over to Jennifer, who's our leader for the association, to kind of walk through what the research, right, that GKV drove to design this campaign, and to do a little reveal here and show you what the campaign itself is going to look like.
Great, thank you. Good afternoon, Madam Chair, Vice Chair, members of the committee. My name is Jennifer Bremen. I am the Executive Director of the Maryland Managed Care Organization Association, and I guess today I'm the deliverer of the splash, so hopefully I won't let you down. I'm excited to be here today to share this with you. The administration approved a plan that the MCOs, in partnership with the Maryland Department of Health, have been working on, like Kathleen had said, for the past year, to ensure that our members are prepared for the reinstatement of Medicaid eligibility redeterminations. We completely understand the importance of engaging our members and preparing them for this change, and the MCOs have collectively invested considerable resources to make sure that this is executed well, that the message and the call to action is developed and delivered efficiently to our members statewide, in order for as many individuals as possible to keep their current health coverage or obtain new coverage when the redetermination process begins. To that end, last year we retained Baltimore-based communications agency GKV to help us craft and execute the broad-based, comprehensive, statewide campaign that I'm going to share with you today. You may not be familiar with the name GKV, but you are very familiar with their work, as they were the architects of the Maryland Go Vax campaign, which I'm sure everyone here is very familiar with. And I think everyone will soon be very familiar with what you're about to see today. Let's see. I'm going to share the following items with you today. I'm going to provide you with an overview of the consumer research that was conducted prior to the development of the campaign. In partnership with GKV, we've developed an advertising campaign to generate awareness for the redetermination efforts. We'll share the objectives for the campaign, along with the branded campaign theme and some supporting creative elements. And finally, I'm going to give you a high-level overview of the integrated media plan that will be delivering the messaging. All right. First, I'd like to provide you with an overview of the consumer research that's been conducted. We all understand the importance of research when building a communications plan. The ability to have in-depth conversations with Medicaid members is extremely important when crafting communications that will resonate and prompt action. We partnered with local research firms to conduct one-on-one discussions with our members. There were some key areas that we wanted to explore, which included awareness around the renewal process, potential barriers that exist for renewals, and message points and media vehicles that were a priority for our members. We spoke to a good mix of Medicaid enrollees ranging in age from 18 to 64, along with a mix of genders, ethnic backgrounds, counties of residence, and members from all MCOs. It was extremely important that we had an opportunity to speak with a mix of individuals who had gone through a renewal process and those who have not. Next slide, please. What follows are some key findings from our discussions with members. None of the participants were aware of how important the next renewal period is and that it may put them at risk of losing their health insurance. They were not aware of potential changes coming to their Medicaid eligibility status. This finding was also consistent with research that had been conducted by CMS. For those who had not renewed before, the idea of having to renew was not even on their radar screen. The participants had no knowledge about how the process would work and were confused about when their benefits would expire. When speaking with participants about the possibility of losing their coverage if they do not complete their renewals on time, they noted how concerned they were and indicated that renewing would be a top priority for them once they were notified. A large majority of individuals moved over the past 3 years during the pandemic, as nearly 50% of the participants indicated a change in address. They indicated that interaction with the Maryland Health Connection account has been limited, as only a third of our members indicated that they had an online account and noted that they rarely visited that account. When speaking with our members about potential barriers to renewing, the common responses that we received included they weren't aware of the expiration timing, they experienced a major catastrophe in life, such as a death in the family or an accident, they experienced regular life distractions, and they had issues accessing the site due to limitations with their internet service. Next slide, please. When talking with our members about the organizations that would communicate with them regarding their renewals, along with their current MCO, most associated the Maryland Health Connection name with the renewal enrollment process, and they associated the Maryland Department of Health with credibility. Many members indicated receiving communications from their MCOs and acknowledged how grateful they were to receive these communications. When speaking to members about media channels that would be most helpful communicating about renewals, our members noted that their desire to receive important information through multiple communication channels, including mail, text messages, emails, and phone. One of the most impactful quotes we received from one of the participants was, "Please use multiple ways of communicating, emails, texts, and voicemails. One of them is guaranteed to touch base with me." Messaging that is direct and concise is preferred and should be consistent from all parties. Our members want to know what needs to be done and when it needs to be done by. They don't want to be confused. As this team developed our comprehensive statewide outreach campaign, it was crucial that we achieve the following objectives. We must generate awareness with a campaign theme to brand and advertise our outreach efforts. The campaign must disrupt the current autopilot behavior to let Medicaid recipients know that changes are occurring. We need to change current behavior. Given the urgent need to reach our Medicaid members over the next year, messaging needs to encourage individuals to keep their contact information up to date. And when it's their turn to renew, we must urge them to take action to complete the renewal process. And finally, as we will be working with many other partners on the communications, including community organizations, providers, hospitals, state agencies, and patient groups, we must ensure that the advertising assets that are produced are easily adaptable to ensure that the look and messaging are consistent to limit confusion by the members we serve. Next slide, please. Our creative theme, you can switch the slide, is called the 2023 Medicaid Check-In. As you can see from the branded logo that has been developed, given the familiarity with the Maryland Health Connection brand and its association with the enrollment and renewal process, we've leveraged their colors. We've also used a co-branded approach to include the Maryland Department of Health logo. The campaign theme, Medicaid Check-In, was developed to express that a clear action needs to be taken and that it would not be a burdensome one. We wanted to make it feel easy and familiar to other check-in occasions, such as a hotel or a motel or a hair appointment or a doctor's visit. We did not want to intimidate our members, and we wanted to express the idea of care on the part of someone looking out for you. And finally, the imagery conveys the methods most people will use to check in via computer or phone. Late last year, we had the opportunity to go back to our members again and recheck the creative findings. The reactions to the new creative logo and campaign were very positive. Participants responded very well to the Maryland Health Connection and MDH co-branding approach, with most associating the Maryland Health Connection with the renewal and enrollment process, and our members felt the MDH logo added credibility to the message. Participants responded very well to the eye-catching and appealing colors of the campaign, and they also valued the multiple ways to engage, including the 800 number and the QR code that was provided. And they indicated that the messaging is direct and concise and is preferred. Next slide, please. We will be executing a pre-launch campaign. The goal of the phase of this campaign is to encourage our members to update their contact information. We've developed numerous creative assets, and I'll briefly walk you through them. First, you'll see here we have a flyer that leads with a headline, "Keep your info current, keep your insurance." We then call out that changes are coming to Medicaid, and we encourage our members to update their contact information. We have designed a two-sided flyer that provides some additional information. Email, copy, and designs have been developed and will be provided to the MCOs to reinforce that messaging. We also have a mix of paid social media ads that will run on Facebook and Instagram, all encouraging our members to keep their information current. And Kathleen, you can click through. These are just some of the flyers you see here, all consistent, showing how they would be. And these are some of the social media ads that will run in the first phase of the campaign, just giving you an idea what they look like on a mobile device and what they would look like on a computer. These paid, and yep, we'll stop right there. The paid social media ads will also include the use of video to further express that updating your information is easy to do and not a stressful experience. The MCOs will also be sending out text messages that will be consistent in messaging. Here you see an example of one that will go out to members. We'll also promote the Medicaid Check-In logo on our state agency partner websites, including the Health Connection site, as you'll see here, so the audience easily recognizes the logo and it will help with user experience on the site. A similar logo placement will be found on the DHS and DDA websites to assist fee-for-service Medicaid members and keep the messaging and logo consistent program-wide across both Health Choice and fee-for-service. The campaign logo, when clicked on, will drive individuals to a dedicated landing page on the Maryland Health Connection website. And go ahead to the next slide, which will provide more text that will be formatted differently, but it will go more into details about their next steps for renewing their coverage. Next slide, please. Next, we'll go to the media plan overview. I'll take you through the integrated media plan that will be executed to deliver the advertising. When developing our media plan to reach our Medicaid members, we will use an integrated mix of media vehicles that reflect our members' preferences. The campaign will include traditional paid media, such as statewide television, radio, and out-of-home advertising, including billboards and outdoor media, as well as a strong digital advertising component, given the high internet usage of our members. This campaign will work in tandem with each of the MCO's plans to outreach to their individual members as well. Hispanic media outlets have also been incorporated into the media plan to reach our target audience. The campaign will be conducted over 2 phases. A pre-launch campaign will be conducted starting February 28th, just later this month. The goal of this phase of the campaign will be to generate awareness and to encourage Medicaid recipients to update their contact information. This will be focused on paid social media channels given the high usage of mobile devices of our members. The second phase will be the launch phase, which will continue to encourage members to keep their contact information updated, as cohorts will be up for renewal on a rolling basis over 12 months. However, the campaign messaging will include a strong call to action to renew when it's their turn. This will be a larger integrated media campaign slated to start on April 12th. Based on the research we conducted and the national research we have seen, it's imperative that we provide multiple ways for our members to interact, whether it be through a web address, an 800 number they can call, a QR code for easy access via their mobile device. As mentioned earlier, the campaign will direct individuals to a dedicated web page on the Maryland Health Connection site where they will have access to their online account. You'll see in front of you a flow chart of the media campaign. I know this looks a little overwhelming, but this is a high-level overview of the media plan. As I mentioned earlier, given the renewal process will occur over 12 months, and it's crucial that we have a media presence for each of those 12 months, covering each of the 12 cohorts of member renewals at a statewide level. All the way to the left of this grid is the pre-launch campaign focused on paid social media. The pre-launch campaign is focused on paid social media and will start again on February 28th. As a reminder, this pre-launch campaign will encourage individuals to update their contact information. The full launch campaign, again, will start on April 12th. We will have TV advertising to officially kick off the campaign and help with awareness. It will be used tactically throughout the year. Traditional and digital radio will also be utilized. We'll have a steady presence through digital and social media channels that will deliver impactful messages and drive responses. And where there are geographically higher concentrations of our members, targeted out-of-home advertising to include transit advertising will also be incorporated. We also plan on using location-based media to include poster advertising at convenience stores and laundromats, as well as advertising on receipts at Family Dollar and Dollar General stores. There will also be a coordinated plan with our MCOs to develop a grassroots outreach campaign to reach those hard-to-reach audiences and non-English speaking Medicaid members throughout the state. In addition, we have an earned media and public relations effort, which is going to be incorporated into this overall strategy. And we also have in development a provider toolkit, which Tricia had mentioned earlier, which will help our Medicaid providers to leverage in assisting their patients in navigating this process. It will include tools to help providers access their patients' redetermination dates. It will include resources with messaging and links to update their information with the Maryland Health Connection, as well as message reinforcement with ads on TV monitors within physician waiting rooms to reach our members during their medical appointments for themselves and their children. I know that I've presented a lot of information during the splash here today, as it's a really robust campaign, but it has to be robust. It has to reach our 1.7 million members statewide beginning later this month. This has been a top priority for the MCOs for many months, and we believe this comprehensive strategy will mitigate the number of individuals that will lose coverage once redeterminations begin later this spring. And I'm grateful for your time and your attention, and we're happy to take questions.
Thank you. I know Kathleen is there. Would you like to be heard or? Okay.
Today, as the legislative chair for the MCO Association and as a resource, just as a footnote, I have been involved with this program since the inception and was actually down here back in '96 and '97 when we legislated to have the managed care program established.
Thank you. Just want to make sure we didn't miss you. We do have questions. The first one is Delegate White.
Yes, good afternoon. Thank you so much for sharing, as well as having our opportunity to see this campaign. So I wanted to know if you are, outside of providers, are you also engaging with trusted community voices and partners in spreading the word, and is a social media or a media toolkit available for them, especially in the nonprofit community that may also be serving the same population?
Absolutely. We are looking to partner with any trusted voices in the community that are looking to partner. Along with GKV, that has those a lot of the connections, especially from the GoVax campaign, when a lot of times it was the same voices and getting into the same communities that had the same challenges of reaching and getting those the Medicaid population that actually had the lower vaccination rates, and reaching those populations and using those same trusted voices to let those folks know that this was something that needed to happen in those communities, and rely on those trusted voices to get the vaccination rates up. We're going to be working with them to get back in the same communities, using the same trusted voices in this campaign as well. But as as an association, we're willing to work with any community partners, organizations, nonprofit groups, to partner to spread the message as far and wide as possible. Absolutely.
My pleasure. Delegate Taveras.
Thank you. Thank you. Thank you so much for presenting. I mean, this is something that, that this is super important given everything that's at stake. How much of an opportunity was given to maybe figuring out how this messaging would resonate in other ethnic communities? For example, just to, because right now I don't see anything in Spanish. I don't see anything in other languages, and I don't see how it would, like, for people who are, who are not literate, how they would receive it. Or in my community, just checking in, like a lot of people, the way they communicate is through WhatsApp. So just figuring out just different ways to target. I don't think that I think that we can still obviously use what's there. I'm just saying, like, how was any thought was put in?
All of our research focus groups included a mix of our members only, health choice members from all ethnic backgrounds. All of the resources that you see will be translated. Just what I showed you today was just an example, but everything will be translated into Spanish. and available. Right now, we haven't thought about going that route on the social media. Right now, we're just looking at Facebook and Instagram, but that's a great idea that I'll take back. But please know that the messaging was tested with our members extensively of all ethnicities, and it will all be translated. Yes, everything that is available. And all of our paid media will be on Hispanic media, TV, radio, newspaper, and through all those channels. So,
Thank you so much.
Yep.
Any questions, any other questions? I have to say that what did us, the splash for me was the receipt on Family Dollars. Wow, I've never heard of that. That you can advertise on the receipts, which is really wonderful. Thank you for all your efforts and for caring. You can clearly see from your presentation. So consider us a partner. Our membership here, we have 23 members and we all represent different districts. And I would encourage our members to get in touch with you offline with the particular organizations, nonprofit, or any organization, trusted sources that you think that in your community they should be working with. Will you be so kind and please send them the information, okay? You're all welcome. And I know that I could do this because I met earlier with Kathleen Wee, and I know that she's looking to partner with you. So if you could send that to them offline, that would be wonderful, okay? Thank you so much, and you have a wonderful, blessed afternoon. So for the committee, this is actually the conclusions of our briefings. It is 2:41. If you will be so kind and be available at 3 o'clock, we want to give staff some time to create another Zoom room, and then we will immediately start with the bill hearings for today. And we have actually 4 bill hearings, and I believe we have at least 16 witnesses. So if we could just be ready to start at 3 o'clock. There's also something to eat in the committee room. Feel free to go there and get something to eat or drink. For those of you that have been with us, thank you so much for being with us today. And we'll see you at 3 o'clock for the bill hearings. Thank you. Trying to